안녕하세요. 서울대학교 보라매 병원 이호입니다.
Greetings, I'm Professor Iho of Seoul University Hospital Borame Medical Center. Today I'm going to talk about digital guided implant surgery. Digital guided implant surgery is doing implant surgery using surgical guide that has been fabricated using digital dentistry. By digital, it refers to the entire process before executing surgery. Oral scanner or model scanner is used to get tooth surface data. CT is taken to get CT data, and on computer, this information is utilized for simulation. This is then turned into a reality in the form of guide for surgery. Before proceeding forward, I want to talk about digital dentistry, which lays the foundation for digital guided implant surgery. Input, design using computer, and output. This is the process. In the input step, as mentioned, the oral scanner, model scanner, CT are utilized, and this is input into the computer, and on the computer program we can design prosthesis or guide or orthodontic appliances. You can mill or 3D print the design in the digital dentistry process. Let's compare the order of fabricating single crown between conventional analog method and digital dentistry method. In the case of conventional analog way, you need to prep crown and take impression. Wax up is done, casting is done, and crown becomes complete. The digital process is basically the same. Scanning is done, which is equivalent of taking impression, and design is done on computer, which is equivalent to analog wax up. Milling is done, which is equivalent to casting. Let's do comparison. In terms of patient discomfort, conventional impression is more uncomfortable compared with scanning. Especially if patient has a gag reflex, they feel really uncomfortable. The time taken for taking impression is in general longer compared with the scanning. After taking impression, physical model needs to come out. We need to have a physical location where we can store the model. In the analog method, however, in the case of digital dentistry method, you do not require a physical location. If you look at the wax up process, this is about how closely you can copy the natural tooth before it becomes prep. In the case of wax up, it can be quite difficult, but when you use intraoral scan and design on the computer program, you can scan the tooth before prep and utilize it in the design. Therefore, in terms of copying natural tooth, it's more convenient. In the case where remounting is required, in the case of conventional method, the remounting process takes up more time than thought. But in the case of digital dentistry, you can just insert the changed byte data and alter the design on the computer program, so remounting process is more simple. In terms of casting needs to be done manually. Yes, there's an initial burden of buying the milling machine in the initial phase, but in terms of long-term perspective, if you consider the HR cost, digital dentistry is more favorable. From start to finish, you need to do again in the case of analog method, but you can make adjustments very simply in the case of digital dentistry. As mentioned, in the case of digital dentistry, compared with analog method, it has clear and sure advantages. Prosthodontics, orthodontics, orthognathics. I did not mark it here, but in terms of oral cancer treatment and rehabilitation, digital dentistry is actively applied in all these areas. In the case of prosthodontic face, you can use it for implant guide, custom abutment, and zirconia, ceramic PMMA crown, and even denture. For orthodontics, it can be used for transparent aligner, indirect bracket bonding zig, and night guard. And for orthognathics, it can be used for surgical wafer and surgical guides. As an oral maxillofacial surgeon, I use digital dentistry frequently in doing orthognathic treatment. Let me share with you a case. The patient's chief complaint was about lower protrusion, but you can also see facial asymmetry here. If you look at simulation data, bone surgery was planned in order to resolve asymmetry, and a wafer and cutting guide was fabricated in order to make the simulated data into reality. After surgery, you can see that lower protrusion has been improved, and compared with before surgery, facial asymmetry has been improved significantly. Digital dentistry can be used very frequently for patients with facial asymmetry. Moving on to digital guided implant surgery. When we plan for implanted treatment, this can largely be divided into surgery-driven plan and prosthesis-driven treatment plan. By surgery-driven treatment plan, it means that when placing implant, you place the implant where there is sufficient bone. And the prosthodontic complications that occur due to wrong position are addressed prosthodontically. The downside of a surgery-driven implant placement is that although the crown position should be like this considering interarch relations, because implant is placed where the bone is, the implant inevitably experiences more lateral force. This is a typical issue that can occur due to surgery-driven approach. Due to slightest difference, the implant can be inclined distally and you can end up with cantilever type of prosthesis, or in the case of upper anterior case, you may not be able to provide SCRP type prosthesis. Surgery-driven treatment plan can be more convenient for the surgeon. However, the purpose of implant treatment is not to do surgery. It is to provide crown and to allow patient to use it appropriately. When planning implanted treatment, it should be prosthesis-driven rather than surgery-driven. We should stick to top-down treatment method. In order to provide a top-down treatment plan, we provided this kind of treatment before digital dentistry emerged. On the model, in the desired position, crown were aligned, and putty was used to make scaffold. Resin for orthodontics was used to fabricate guide like this. Analog guides were used for surgery. It was severely oriented around the crown. If we align the crown on the model accordingly with the upper and lower teeth, the implant should be positioned here. However, we cannot realistically place it here because there's too much defect on the buccal side, so we need to make a compromise and change the implant position. We cannot make a guide only based on surface data. There can be issues. This is a 68-year-old male patient with controlled diabetes and hypertension. Rather than analog guide, digital guide was included in the treatment plan to place implants in number 15 and 16. On the program, just like we align the teeth on the model, we align crown. Basic position, rotation, angulation, inclination. We align teeth considering antagonist relations. On the buccal side, we can check this. We can also look at the posterior and lingual aspect as well. We align crown in an ideal position. We can confirm this in different angles. If you don't like it, you can easily change positions. Once crown position is set, we can determine where the implants should be positioned. In the case where implant position is where it does not make sense, or if it is too close to adjacent tooth, then we need to adjust implant position to the point where it does not alter crown position. We can overcome the downside of analog guide. We can utilize surface teeth data and bone data to fabricate digital guide. We can get a tool where we can apply it realistically in surgery. Surgery was performed using the fabricated guide. On the CT, you can see implants have been positioned nicely. In this case, a crestal approach was used and prostheses were delivered. As shown, the biggest benefit in digital guided implant surgery is that you can treatment plan based on top-down approach. No matter how deft you are with your hands, when you do freehand surgery, there can be a bit of movement, and according to some literature, there can be over 1 millimeter of deviation. Thus, there are clear limitations to freehand surgery. When placing implant in an area which requires precise control, such as immediate implant placement in the posterior area or upper anterior area, you can inadvertently touch upon the adjacent tooth or make other kinds of mistakes. If you look at the guide template, the template hole and guide barrel all help us overcome the fundamental limitations of manual work. We can perform flapless surgery in a more safe manner. In simulation stage, we can fabricate temporary crown ahead, and right after surgery, we can deliver it to the patient. Now I want to summarize. There are clear advantages to digital dentistry. The biggest benefit in doing digital guided implant surgery is that we can use top-down treatment plan or prosthesis-driven treatment plan. This is what I've prepared thus far. If you're interested in more in-depth knowledge and practical hands-on course, please refer to offline master course. I look forward to your interest. Thank you for watching.